Hello everyone and welcome to today's live broadcast, T2Sepsis Solution, Diagnostic Value and Practical Application in Real-World Hospital, presented by Dr. Patricia Muñoz from the Division of Clinical Microbiology and Infectious Diseases at the Hospital General University Gregorio Marañón in Madrid, Spain. I'm Susie Valdez of Lab Roots and I'll be your moderator for today's events. We're delighted to bring you this educational web seminar presented by Lab Roots and sponsored by T2 Biosystems. T2 Biosystems is developing innovative diagnostic products aimed at lowering mortality rates, improving patient outcomes, and reducing the cost of healthcare by helping medical professionals make targeted treatment decisions earlier. With 2 FDA-cleared products targeting sepsis and a range of additional products in development, T2 Biosystems is an emerging leader in the field of in vitro diagnostics. Before we begin, I want to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. Just click on the green Q&A button located at the lower left of your presentation window, type those questions into the box that appear on the screen, and we'll answer as many questions as we have time for at the end of the presentation. Also, please notice that you will be viewing the presentation in a slide window. To enlarge that window, just click on the screen icon in the lower right. If you have trouble seeing or hearing the presentation, please click on the support button at the top right of the presentation window or use that Q&A button and let us know you're having a problem. This presentation is educational and thus offers continuing educational credits. Please click on the button at the lower left corner and follow the process for obtaining your credits. I'd now like to introduce the speaker, Dr. Patricia Muñoz. Dr. Muñoz studied medicine at the Universidad Complutense of Madrid and did her residence in the Hospital Clinic San Carlos of Madrid, where she completed several research and clinical fellowships. Under the mentorship of Professor Emilio Bouza, she did a fellowship in infectious diseases at the Hospital General Gregorio Marañón, where she was accepted first as a research fellow and later on the staff. At present, Dr. Muñoz is a professor of medicine and clinical microbiology at the Complutense University of Madrid and is the head of the infectious disease section at the Division of Clinical Microbiology and Infectious Diseases at the Hospital General University Gregorio Marañón. Please join me in welcoming Dr. Patricia Muñoz. Welcome, Dr. Muñoz.
Hello, everybody. This is Patricia Muñoz from Madrid in Spain, and I have the pleasure to share with you our experience with the Candida T2. Here you have my disclosures. Let's begin with a brief introduction. If you are hearing this webinar, you are positively aware of the importance of Candida infections. Candida infections actually account for approximately 6% of nosocomial infections, and unfortunately still carries a high mortality rate. In certain populations may even reach 40%. We are perfectly aware of the importance of controlling the source and of providing rapid, effective antifungals. As you can see in the slide, if you are not able to do both things, to provide treatment in the first 24 hours and to control the source, the mortality of your patients will be extremely high. Some years ago, this paper, you can see in the slide, also demonstrated that even slight delays in starting effective antifungals had a great impact on mortality. The difference between starting antifungal on day 1 with 25% mortality and day 2 with 35 or even 40-something mortality, if you studied it later, is very impressive. So why do we have all these problems for treating patients with candidiasis? It is because the diagnostic methods we have are not perfect at all. We have been using for years clinical scores to identify patients in which the probability of candidiasis is high as to deserve empiric treatment. And we have been using the Ostrowski scores, the Candida score, the colonization index, etc. But as you can see in the slide, although the negative predictive value of all these scores is good, the positive predictive value is extremely low, thus making us treat unnecessarily hundreds and hundreds of patients. Of course, we still rely on blood cultures, but blood cultures have poor sensitivity, less than 50% in most studies. Fortunately, new methods not based on culture appear, and we have been using for years now the Beta-D-Glucan. However, the Beta-Glucan test may have false positives. They were 35% in our recent study, and also false negatives in certain patients and infections. So, at the end of the day, we have difficulties for identifying who are the patients at risk of Candida infection, the patients at risk of poor outcome, and in patients with demonstrated candidiasis, who are the patients at risk of complicated disease. Which is the result of all these problems? That physicians nowadays tend to use broad empirical treatment and usually maintain therapy for proven infections, probably for very long periods of time. So in summary, we rely on blood cultures with the limit of detection of less than 1 colony-forming unit per ml and low sensitivity. We have MALDI-TOF, but MALDI-TOF will help us in identifying the identity of our yeast, but needs a positive culture. And we have already spoken about the problems with Beta-D-Glucan. So some years ago, T2MR for Candida detection appeared, and it was a great breakthrough. As you know, it is based on the nanodiagnosis of viable Candida microorganisms. It detects the most 5 common Candida species. It is going to be improved and detect more species. And more importantly, it detects the Candida in whole blood. You don't need to wait for the positivity of a culture. So with a fully automated methodology, you will have your result in 3 to 5 hours. This was the most important paper that made all our heads turn to the T2 magnetic resonance assay. It was published some years ago in CID. It included more than 1,000 patients with positive blood cultures, but only 4 candidemias in this study, and 250 spiked blood culture bottles and controls. The results were extremely good. Sensitivity higher than 90%, specificity almost 100%. So we decided to do 2 studies. The first one is a study on patients with candidemia, and the second one is a study on patients who merit empiric antifungals. So let's begin with the first one, the candidemia study. Once you have candidemia in one of your patients, you have to differentiate patients with complicated candidemia from the patients with uncomplicated candidemia. As you know, patients with candidemia may have septic metastasis, may have poor prognosis, or are relatively benign disease. An early differentiation between those 2 settings is usually based on blood cultures, and we have already mentioned that blood cultures have a lot of, let's say, false negative results. So if you have a patient with persistent positive blood cultures, of course you are in front of a complicated candidemia, but if your patient does not have persistent blood cultures, you still may have a complicated disease. So what does the guidelines recommend? Guidelines recommend to perform follow-up blood cultures with a strong recommendation, although based on low quality evidence. And for most patients with positive blood cultures, you will have to do ophthalmoscopic evaluation, echocardiogram, and you will decide the length of treatment according to the positivity of blood cultures and to the findings on those complementary tests. So, starting with this situation that candidemia may or may not be associated with septic metastasis, we decided to start our study with the objective of assessing the usefulness of follow-up T2 in comparison to blood cultures and Beta-D-Glucan to early differentiate patients with complicated or uncomplicated candidemia. We performed a prospective multicentric study in 3 hospitals in Madrid, Spain. Patients included were all adults with candidemia recruited from January to June 2017. As soon as we received the first positive blood culture with Candida, index blood culture, we obtained blood samples on days 0, 2, 4, 7 and 14 to perform T2, blood cultures and Beta-D-Glucan simultaneously until the tests were negative. For predicting the diagnostic performance of the different tests, we divided the results, or we analyzed the results at 2 different times. The early period, results obtained from day 3 to 5, and late period, results obtained beyond day 5. What was our definition of complicated candidemia? For our study, we classify a candidemia as complicated when the episodes involve metastatic lesions in other organs or when the patient died during the follow-up period, which was 1 month. So very strict definition. Here you have the recruitment. We recruited patients in Hospital 12 de Octubre, Gregorio Marañón, and Ramón y Cajal. Initially, we recruited 44 adult patients. However, 14 had to be excluded. 6 because they died in the first 2 days, 5 didn't sign the informed consent, and in 3 cases, we got invalid T2 results. So finally, we could analyze 30 patients with candidemia. Half of the patients were male and mean age was 66 years old. Here you have the first result. When you analyze your candidemias, 70% will fulfill our criteria of uncomplicated candidemia, and the remaining 30% did have metastasis or died during the follow-up, and they were thus classified as complicated. Here you have the epidemiological characteristics of both populations, uncomplicated in blue and complicated in red. As you can see, the population is very normal, similar to what you may find in most tertiary hospitals. Half of the population were male. Most common underlying disease were malignancies, diabetes, cardiovascular problems. The McCabe score was non-fatal in approximately half of the patients. The Charlson comorbidity index was between 3 and 4, and the risk factors for candidemia were also the usual ones: central venous catheter, parenteral nutrition, previous surgery, or corticosteroid therapy. And as you can see, there were no clear differences between both populations that would allow you to identify who is at risk of having a complicated candidemia. When we move to the clinical characteristics of the patients, again, no difference in bloodstream source. Most of them were catheter related, but there were also abdominal or urinary tract candidemias. No difference in species. Albicans, Parapsilosis, and Glabrata were the more common and they are the more common in our country. Patients with complicated candidemia did present with more severe disease. There was no difference regarding source control, which was pretty high in both arms of the study, around 70–80%. Patients had received a mean of 2 days of antifungal therapy before recruitment, and the hospital mortality was clearly higher in patients with complicated candidemia, although the difference did not reach statistical significance, but it was 5% versus 33%. And look at here, the length of therapy was clearly longer for patients with complicated candidemia, 39 days versus 18. Let me just start with a clinical example. Here we have a man of 60 years old with a tongue carcinoma in 2004 and afterwards a supraglottic squamous cell carcinoma. He underwent surgery, chemotherapy, he needed a central venous catheter and underwent complete remission. However, on November 2016 developed his first local recurrence requiring surgery, and the postoperative course was complicated with catheter-related candidemia due to Candida tropicalis. It required the removal of the portacath and 14 days of therapy. However, some months later, a couple of months later, in January, he developed again recurrent candidemia. We moved to a echinocandin treatment, even though the strain was susceptible, and performed follow-up blood cultures, and they came negative. However, we were very aware of the high risk of endovascular infection when you have late recurrence of candidemia based on our previous experience. As you can see, patients who recur in the first 2 or 3 months usually have endocarditis or septic thrombophlebitis, so we perform an echocardiography, and the patient proved to have an infective endocarditis affecting the right heart, the tricuspid valve. In the figure, I have summarized for you the results of the blood cultures in red, of T2 in blue, and Beta-D-Glucan in green. As you can see, blood cultures were positive, then negative when we started treatment, and again positive. However, T2 in blue was positive all time along, even after surgery. After surgery, blood cultures were immediately negative. However, the T2 was positive for 1 more week, and this was because the patient was proven to have pulmonary metastasis of the infectious endocarditis. So let me show you in the same type of figure our uncomplicated candidemias. I'm not going to describe every single patient for you. You have them summarized in the slides. However, I want you to just look at the blues. We are talking about uncomplicated candidemias. You see that very commonly the Beta-D-Glucan at the bottom remains positive. Then from time to time you have positive blood cultures. Here you have more patients, but you can see that we have very few blues. Here in patient at the bottom, here you have 1 blue, but this was because the catheter hadn't been withdrawn. The moment the catheter was withdrawn in this uncomplicated candidemia, the T2 became negative. But the Beta-D-Glucan, as you can see, remained positive. Here you have more uncomplicated candidemias, and they were only positive, the T2, in patients in which the source had not been properly controlled. Let's move now to complicated candidemias. As you can see, here all the patients have blue. In all the cases, the T2 was positive. We have 1 Candida parapsilosis with intra-abdominal and ocular metastasis. We have 1 Candida thrombophlebitis with ocular metastasis. We have 1 endocarditis with lung metastasis, and here another ocular infection. Again, patients with complicated candidemias, and in all the cases, you have the T2 that was positive. In summary, when we analyze all the patients together, at least one positive surveillance test was obtained in 33% of the blood cultures we took, but in almost 60% of the T2s. And look at this, only half of the patients with a positive T2 had a positive concomitant blood culture. When we divide our samples in early samples and late samples, you can see that blood cultures were positive during the first 5 days in 30% of our patients, T2 in half of them, and practically all the patients had a positive beta-D-glucan, so it wasn't really of help for an early differentiation of these two populations. When we move beyond the first week, blood cultures remain positive only in 2 patients, 6.7%, but T2 in 23% and beta-D-glucan is still positive in practically 65% of the patients. So when we analyze both populations, uncomplicated and complicated patients, as you can see, the only test that provide a significant difference between them was positive T2. That was positive in only 23% of the uncomplicated patients, but in 100% of the complicated patients. Regarding late samples, again, T2 was the only one providing significant difference. Which was the sensitivity, specificity, positive predictive value, and negative predictive value of the 3 tests, blood cultures, T2, and beta-D-glucan, for detecting complicated candidemias. You can see them in the slide with their intervals of confidence. And as you can see, T2, both in the early and late period, were the ones providing best results. We then perform a multivariate analysis for predicting complicated candidemia, and as you can see, an early positive T2MR result was an independent predictor of complicated candidemia with an odds ratio of 36.5. So the conclusions of our first study was that a T2MR test performed in patients with proven candidemia may be a better marker of complicated infection than follow-up blood cultures or beta-D-glucan assay. Purportedly, this test may influence the length and type of antifungal therapy in this population. This is a picture of Madrid. So come and visit us. You can see our T2 machine in our hospital. And let's then move to the second study. The second study is a different setting completely, because now we are focused on patients who deserve empiric antifungals. Empiric antifungal therapy is a very common practice in high-risk patients in the intensive care unit, in surgical departments, and in other departments of the hospital. However, its utility has been recently challenged, as you are aware in the empirical study. It is very common practice. And most times, blood cultures will remain negative, but the treatment is maintained for 10 or even more days. It is very difficult to stop antifungals in a very high-risk patient once you have started them. So, in order to avoid unnecessary prolonged treatment courses, new diagnostic methods are clearly needed. Non-culture based techniques and serological biomarkers are used to stop antifungals. Beta-D-glucan is used, and we have published a paper using 3 consecutive negative samples for stopping antifungals, And Nucci in Brazil has published a study using 2 consecutive negative beta-D-glucans only in intensive care unit patients. But these strategies, both the 3 consecutive negatives and the 2 consecutive negatives, will require at least 5 or 7 days before you have the results. So patients will be treated unnecessarily for that period, if not more. And what is the effectiveness of using this biomarker approach? As you can see here, you have the results of my institution that were published a couple of years ago. We were consuming, as you can see here, in US dollars, almost $4 million in antifungals, in acquisition cost of antifungals. So we started our stewardship campaigns first with education, and we saved some money. Then we started with our bedside advice, and we also were very successful, and it maintained, the effect is maintained in time, as you can see, and it is even improved with the use of beta-D-glucan. So you can save money for your institution, and you can save toxicity for your patients. So the objective of this second study was to assess the potential role of T2MR alone or combined with those serological biomarkers, beta-D-glucan and CACTA, and also with standard cultures for the early identification of patients who will have a good or a poor evolution. It was an observational prospective pilot study. We didn't stop treatment. It was a pilot study. The inclusion criteria were adult patients, non-pregnant, non-hematologic, receiving adequate empiric antifungal treatment for less than 3 days according to the IDSA guidelines for suspected candidiasis. Here you have our methods. Samples were collected on day 0, on day 2, and on day 4 for beta-D-glucan, Candida albicans, herm tube antibodies, I will call this test CACTA from now on, and for T2MR. Our cutoff for beta-D-glucan was the standard 180. Our endpoint was the value of the T2 alone or in comparison or in combination with the biomarkers to predict poor outcome. And what was poor outcome for us? Poor outcome included either having a diagnosis of fungal infection, dying within 7 days of antifungal therapy without another definite identifiable cause, because those patients who died early may probably have died because of an undetected fungal infection. Here you have the hospitals that participated in this study. Our hospital, Hospital Gregorio Marañón, Hospital Clínico San Carlos, Hospital 12 de Octubre, and Hospital Ramón y Cajal. We recruited 55 adult patients with clinical suspicion of invasive candidiasis from January to June 2017. 5 patients had to be excluded. In 3 cases, we had an invalid T2 result. In 1 patient, the infection was caused by Candida kefir, which is not detected by the T2. And 1 patient did not sign the informed consent. So at the end, we had 49 patients. Here you have the first result. 35 patients had good outcome, no fungal infection, and survived. And 14 patients had poor outcome because 7 died and 7 had a proven invasive fungal infection. The diagnosis of invasive candidiasis overall was then established in 7 of the 49 patients receiving empirical treatment in an institution in which an antifungal stewardship program has been working for years. So even in our institution, only 14% of the patients who receive empiric antifungal really need the antifungals. What type of infection did these 7 patients have? One patient had an esophagus perforation and Candida was recovered from the pleura, so it fulfilled the criteria of proven infection. One Candida albicans pleuritis. The other 6, were intra-abdominal candidiasis. And the samples had been taken in the operating room, so they were fulfilling the definition. Only one of them had candidemia. The remaining 7 patients died early with no other clear explanation, so they were considered failures as well. Here you have the comparison of the clinical characteristics of both populations, the 35 with good outcome and the 14 with poor outcome. Same age, same sex. They were admitted, most of them, in the intensive care units of our hospital, almost 80%, but the other 20% of empiric treatment is provided outside the intensive care units. As underlying diseases, again, gastrointestinal diseases, neoplasia, cardiovascular, and chronic liver disease were the most common. Both populations have 3 as a mean Charlson comorbidity score, and all of them had plenty of reasons for receiving empiric antifungal therapy. Broad spectrum antibiotics, central catheters, severe sepsis or septic shock, surgery or total parenteral nutrition, as you can see in the slide. But no differences in both populations, so you cannot say early which one really deserves antifungal therapy. Regarding type of antifungal therapy, we usually start with echinocandins, so practically 90% of both populations receive initially an echinocandin. Not many of them were previously colonized, no difference in both populations again. A huge proportion of the patients needed mechanical ventilation, as you can see, so they were really, really ill. Patients, by definition, had received only a maximum of 2 or 3 days of previous antifungal therapies, and look at the duration of antifungal therapy. Patients with good outcome, everything in favor, blood cultures negative, good evolution, receive a mean of 8.5 days of antifungal therapy, probably not needed, and patients with poor outcome, only 12 days, because half of them died. But the patients who survived receive a much longer duration therapy. When we look at mortality, early mortality was 50% in the poor outcome by definition, and in hospital mortality was 64% in the patients with poor outcome. How did the 3 biomarkers perform? Here you can see the results of the CACTA. CACTA at baseline, day 2 and day 4, and in blue, population with good outcome, and in red, poor outcome. As you can see, CACTA is not helpful for separating these 2 populations. What about Beta-D-Glucan? Again, was not helpful, because Beta-D-Glucan was positive in a very high percentage of patients in both groups, because they are patients in the intensive care units, they receive antimicrobials, they are operated on, and they may have a positive Beta-D-Glucan. What about T2? Here T2, surprise, surprise, was the only one which could differentiate both populations. And most importantly, the most useful test was the baseline. So you could have a tool on day 1 or day 2 that could help you differentiate patients who really require antifungals and patients in which you can stop antifungals. We then analyzed the sensitivity, specificity, positive predictive value and negative predictive value of the 3 tests, baseline, day 2, day 4. And as you can see here at the bottom of the slide, again, the baseline T2 test was the one performing best. We then wonder if perhaps combining T2 with biomarkers or with cultures increase the results of the test, and indeed a combination of T2 plus standard cultures do increase the performance of the test, because of course you may have some species that are not detected by T2, so you have to take into account both the T2 and the cultures. When we analyze the area under the curve, again, the combination of T2 and conventional cultures provided the largest area under the curve. So to conclude our second study, we believe that in patients receiving empirical antifungal treatment due to suspicion of invasive candidiasis, a positive T2 is associated to a high risk of poor outcome, defined as either proven invasive candidiasis or early mortality. So we believe that T2MR could be a useful tool in antifungal stewardship programs. Let me finish by thanking you and thanking all the team members from my hospital, the head of the department, Emilio Bouza, Marina Machado, Carmen Martinez, myself, I thank myself, Raquel Navarro, Carlos Sanchez, and Antonio Vena, people in Hospital Clínico San Carlos, Fernando González and Paloma Merino, in the Hospital Ramón y Cajal, Jesus Fortun, Francesca Gioia and Elia Gómez, and in the Hospital 12 de Octubre, José María Aguado, Mario Fernández, Francisco López Medrano, María Ángeles Orellana, and Julia Orihuén. Thank you very much, and we are ready here for your questions.
Thank you so much, Dr. Muñoz, for that informative presentation and your important research. We will now start the live Q&A portion of this webinar. If you have any questions you'd like to ask, please do so now. Just click on the green Q&A button at the lower left of your presentation window, type those questions into the box that appear on the screen, and click the send button. We'll answer as many questions as we have time for. So let's get started with our questions from our audience. We have a great audience today. Our first question is, Dr. Muñoz, would you replace the blood culture with T2?
Thank you, Susie. No, the answer to that question is clear for me. For the time being, you cannot replace blood cultures with T2. First of all, patients may have concomitant candidemia and bacteremia, and T2 yet may not detect some rare species. So for the time being, we need both cultures and T2.
Thank you, Dr. Muñoz. Our second question from our audience is, do you see this as a diagnostic test or a prognostic test?
Well, this is a very good question. I see it as both. It is undoubtedly a diagnostic test, it is clear, and it is a prognostic test. For example, in our second study, in the patients with empiric antifungal therapy and no proven diagnosis when the treatment was started, the early T2, the T2 performed in the first 2 days, clearly identified a small population which are very high risk of dying, more than 50%. On the other hand, in the candidemia study, T2 clearly identified patients with high risk of complicated disease, septic metastasis, or also dying. So it is both a prognostic and a diagnostic test.
Thank you. And I want to thank our audience for their wonderful participation today. We have a time for a couple more questions. Our next question is, what would you do differently in the patients that you found positive by T2 in this study?
Let's begin with the simple setting, patients with candidemia. If you start treating a patient with candidemia and your first follow-up T2 is positive, then you really have to look carefully if you have control all the sources, if you have drained whatever abscess or whatever collection, if you have removed the catheters, and you better go and look, perform a fundoscopy and perform a transesophageal echocardiogram, because your patient is at risk of having septic metastasis or an endovascular form of candidiasis. At the end, a very complicated disease. If you are doing a T2 test in a patient without a proven diagnosis yet, then you really shouldn't stop antifungals if you have a positive T2, even if your blood cultures or your conventional cultures of different sites come negative, because those patients really are at high risk or of either proving to have a fungal infection or to die early after the T2 is positive.
Thank you, Dr. Muñoz. We have time for one more question from our audience. Our last question is, can this test be integrated into stewardship?
Absolutely. I think that's the way to go, because a test like this has to prove it's cost effective and should be integrated in antifungal stewardship programs. Our plan is to integrate it in patients with empiric therapy to decide an early stop of antifungals, and probably, perhaps even in patients with proven infection, to determine the length of therapy. So definitely it can and should be a part of the antifungal stewardship programs.
Dr. Muñoz, thank you so much again for your wonderful presentation. Would you like to provide any closing remarks before we close our session today?
Thank you, Susie. Yeah, just to say, it has been a pleasure being able to disseminate our small piece of research to so many people. It would be a pleasure to see you face to face, but I think this way is more convenient. And also to say it has been a pleasure to do our research with the T2MR. We found that it was a really interesting tool for managing patients with invasive candidiasis. Thank you very much for this opportunity.
I want to once again thank Dr. Patricia Muñoz for her presentation. I'd also like to thank T2 Biosystems and LabRoots for making today's educational webcast possible. Before we go, I want to remind everyone that today's webcast will be available for on-demand viewing through April 2018. You'll receive an email from LabRoots letting you know that this webcast will be available for replay. Please share that announcement with your colleagues who may have missed today's live event. That's all for now. Thanks for joining us. We hope to see you again soon. Bye-bye.